to encourage the patient to express concerns about changes in appearance, sexuality, or fertility, identify factors that place patients at risk for endocrine health problems, teach everyone about the dangers of misusing or abusing hormones or steroids, ensure that agency laboratory procedures for collecting and handling specimens for endocrine function studies are followed, teach patients and family members about what to expect during tests and procedures to assess for endocrine problems, describe the relationship between hormones and receptor sites, explain negative feedback as a control mechanism for hormone secretion, and apply the principles of anatomy and physiology to understand the role of the endocrine system in maintaining homeostasis. We're going to do a brief Chapter 64 Anatomy and Physiology review. The first portions that we're going to do is we're going to discuss about the glands that are that composes the endocrine system. Primarily, you have the hypothalamus, the pituitary gland, the gonads, um, the adrenal glands, the thyroid gland, parathyroid gland, and the pancreas. And each one of those have their own function. Um, the endocrine system with these glands work with the nervous system to control the overall body function, and this is known as the neuroendocrine regulation. Many interactions must occur between the endocrine system and all other body systems to ensure that each system maintains a constant normal balance. That constant normal balance, of course, will be what we call homeostasis. Um, you will see on in your textbook figure 64-2, which is page 1360, where it shows about the lock and key hormone receptor binding, where hormone A fits and binds to its receptors, causing a change in cell action, and hormone B that does not fit or bind to receptors, so therefore there will be no change in the cell actions. Um, the positive and the negative feedback system is described here, um, where we're discussing basically what the hypothalamus is. A perfect example is the hypothalamus, which secretes the cortical releasing hormone. The cortical releasing hormone stimulates what they call the anterior pituitary gland, and the anterior pituitary gland basically secretes the adrenocorticotropic hormone. So then, as a result, the adrenocorticotropin hormone then triggers the release of cortisol from the adrenal cortex. And so, as a result, the rise in blood levels of the cortisol inhibits or stops the cortical releasing hormone from the hypothalamus. So, for example, without having cortical releasing hormone, the anterior pituitary gland stops secreting adrenocorticotropin hormone in response to normal blood cortisol levels are maintained. Um, the normal blood level range of each hormone is well defined, and excesses or deficiencies of hormone secretion can lead to any types of pathologic condition. So basically, what that is demonstrating is the positive and negative feedback system. We're going to start talking about where we discussed earlier about the endocrine system, which is composed of the hypothalamus, the pituitary, of course, the parathyroids, the adrenals, the thyroid, the testes, the pancreas, and the ovaries. Okay. When we talk about um, the hypothalamus gland and the pituitary glands, the hypothalamus is, like we said before, a small area of nerve and glandular tissue located beneath the thalamus in the brain. The fibers that connect the hypothalamus to the rest of the central nervous system. The hypothalamus shares a small, closed circulatory system with the anterior pituitary, and that's why a lot of times you'll hear people talk about the hypothalamus and the pituitary glands together. The endocrine function of the hypothalamus is to produce or to regulate hormones. So think about the hypothalamus as being like almost like the control center. The hypothalamus, once again, is to produce and regulate hormones. Some of these hormones are released into the blood and they may travel to the anterior pituitary where they either stimulate or inhibit, which means to stop the release of anterior pituitary hormones. Okay, so um, anyway, with the hypothalamus, like I was saying earlier, was that the hypothalamus has the ability to release hormones into the blood that travel to other parts of the body, mainly the anterior pituitary, and they either stimulate or inhibit the release of anterior pituitary hormones. So, um, as you would discuss this, they have various anterior pituitary hormones, um, which would include like the thyroid stimulating hormone, like I said before, which is the adrenocorticotropic hormone. You have the luteinizing hormone, the follicle stimulating hormone, prolactin, and then you have the growth hormone, and then you actually have the melanocyte hormone. That's on table 64 point dash 2 on page 1361 of your text. The posterior pituitary consists of vasopressin, which is really another word for the antidiuretic hormone, or oxytocin, which is it works for uterine contractions and breast milk. You probably would pretty much have to know that about the anterior pituitary hormones and the posterior pituitary hormones because they will discuss or text you on that area. Okay, I forgot to tell you in response to the releasing hormones of the hypothalamus, the anterior pituitary secretes what they call tropic hormones. Mainly, you'll hear me talking a lot about the hormones that are excreted by the anterior pituitary because in the posterior pituitary you only have what the kidney and the uterus and mammary glands, which consist of the antidiuretic hormone or vasopressin or the oxytocin. So a lot of times you'll hear me discuss about the anterior pituitary. You do want to know that the anterior pituitary secretes what they call tropic hormones in response to the hypothalamus, which are hormones that stimulate other endocrine glands. Other pituitary hormones, such as prolactin, produce their effect directly on final target tissues. So, um, like for instance, the how can I explain this? Prolactin uh, works directly on the mammary glands to stimulate breast milk production, for instance. Hormones are stored in the nerve endings of the posterior pituitary and are released into the blood when they are needed. So, other factors that can affect the release of hormones from the pituitary gland are things like, for instance, drugs, maybe somebody's diet, their lifestyle, and any type of pathologic condition can increase or decrease pituitary hormone secretion. Um, so, you want to talk about the adrenal glands, like we said before. The adrenal gland consists of the adrenal cortex. The adrenal cortex has what they call mineral corticoids, um, which consist of aldosterone, and then they have what they call corticosteroids, which consists of cortisol. Adrenal medulla works with catecholamines, which basically are the norepinephrine and the epinephrine. So you need to be able to distinguish the difference. The adrenal cortex basically has um, two types of things that they work with, which are mineral corticoids. Okay, and then basically those mineral corticoids are like the aldosterone, and you know that the aldosterone help control the body's sodium and potassium content. So adrenal cortex has contains mineral corticoids, which, like for instance, aldosterone. Aldosterone serves to regulate the sodium potassium content in the body. Then also, adrenal cortex consists of corticosteroids. The corticosteroids are the hormones that are secreted by the adrenal, like cortisol and that type of thing. Um, the cortisol is uh, which really regulates like carbohydrate, protein, and fat metabolism. The body, how the body responds to stress, whether or not a person is emotionally stable, and also like maybe even a person's immune function. So you want to keep that in mind. Then you have I do want you to know about the aldosterone, and I do want you to know that the aldosterone is produced in the adrenal cortex. It's considered a mineral corticoid and is secreted by the adrenal cortex. It helps regulate the body fluids and electrolytes, and it maintains extracellular fluid volume. It promotes sodium and water reabsorption and potassium excretion in the kidney tubules. So, if you can just remember that, that will be enough. And then you're going to know the cortisol, which is also produced in the adrenal cortex. And you're going to know that the cortisol is part of what they call the corticosteroids. And they influence the excitability of the heart muscles. Um, they influence the body's response to stress, emotional stability, and anything that has to do with, like your immune function. Then the second part of the adrenal gland. So we already talked about it being in two sections. The second part of the adrenal gland would be what they would call the adrenal medulla, and I said part of that is the catecholamines. The catecholamines are the norepinephrine and the epinephrine. So the adrenal medulla, once again, which is the second part of the adrenal glands, is related to the catecholamines and norepinephrine and epinephrine. The catecholamines receptors of the adrenal medulla works on like the heart, blood vessels, GI tract, kidneys, bronchioles, bladder, skin, liver, pancreas, eyes, and areas like that. Um, you'll often hear people talk about various receptors and stuff like that, like beta 1, uh, working with the heart. And what that does is it increases the heart rate and increases the contractility of the heart. Um, blood vessels, you got the alpha receptors, which do vasoconstriction, and then a beta 2, which is vasodilation. Dilation. You got the gastrointestinal, increased sphincter tone. Then the beta, decreased motility. Um, so like there is a chart, table 64 point dash 4, which is on 1363, and you may want to kind of memorize that chart and know how all those different receptors act on various tissues and what it does to them. And then you also want to know that the catecholamine, which is the norepinephrine, and epinephrine is also responsible for what people call that fight or flight response. And that's because it mainly comes from what they call the sympathetic system. So the sympathetic nervous system, um, which releases the catecholamines, are more responsible for like the fight or flight response in individuals. Okay, then we're going to discuss what we call the thyroid gland. And everybody knows where the thyroid gland is. It's in the anterior neck, and it's directly below what they call the cricoid cartilage. Um, and the thyroid gland is probably what most people would call probably one of the most dangerous glands that we have in our body, because it's really related to control of metabolism. And it contains T3 and T4, which are hormones that increase metabolism. And it also regulates the serum calcium levels in your body. When a person has both increased metabolism from the T3 and T4, um, they generally increase the oxygen usage in the body and the heat production in all the tissues in the body. The two hormones differ in structure though, but basically their functions and stuff are pretty much the same. So it um a lot of times you'll see when we'll talk about, like the disease processes as they relate to um the adrenal gland, and how the hypothalamus basically, okay. So once again, before I got interrupted, you'll find there'll be a lot of those during my taping. um like I said before, the primary causes of the thyroid gland is control of the metabolism, and basically the calcium and phosphorus balance in the body. Um, the thyroid gland generally it functions. It controls the metabolic rate of all the cells. It promotes sufficient pituitary secretion of growth hormone and gonadotropins. It regulates how you metabolize your carbohydrates, proteins, and fats in the body. It also exerts effects on the heart rate and how it contracts. it increases red blood cell production. It can also affect the respiratory rate and drive. It can increase the bone formation and decrease bone reabsorption of calcium, and it also acts as an insulin antagonist. So this is the reason why, when one could say that potentially the thyroid could have a particular problem in the body. Okay. Um, then going forward, the next would be like the parathyroid glands. Let me talk to you real briefly about the parathyroid glands. Um, There are four small glands located in close to within the black back surface of the thyroid gland, and their whole purpose is just to secrete parathyroid hormone. And what they do is they regulate calcium and phosphorus metabolism by acting on the bones, kidneys, and the GI tract. Then you have, of course, we talked about the pancreas, and that being another gland that secretes the insulin in the body. So you want to keep in the metabolism of glucagon, um, and so you want to keep that in mind as well. And I do want you to recognize also about uh, how age affects endocrine systems in adults. You'll look on your chart on chap on 64.1, and it discusses how the changes in the endocrine system is related to aging, and people having changes, and most of the time you'll see that a lot of the tolerance is usually decreased. For instance, if you want to talk about, let's talk about the antidiuretic hormone production. The urine is more dilute and may not concentrate when fluid intake is low. So you'll have probably more decreased antidiuretic hormone production in an adult. Also, you'll have decreased ovarian production of estrogen, which means that bone density in an older person would decrease. You'll have skin will be thinner as a decrease in estrogen. Um, Drier, they'll be more at risk for injury. Um Weight becomes greater than ideal along with elevated fasting blood glucose levels and that type of thing. And they'll have decreased glucose tolerance. They'll have decreased general metabolism. Everybody knows that. So most of the time, people will be less tolerant of cold, and they'll have a decreased appetite. They'll have a decreased heart rate and a blood pressure. So what you want to focus in on is what type of things you would want to do for a patient when they have these particular things occur. Um, what you probably want to do is, like for instance, when we talk about the decreased antidiuretic hormone, you know that because they have dehydration in older people, you want to assess them for those signs and symptoms of dehydration. You also want to make sure that you offer fluids at least every couple hours or so to a client when they're awake. When You got to make sure, like for the bone density that decreases, you want to teach the patient to engage in regular exercises and weight bearing exercises to maintain bone density. Um, you also want to avoid, like, especially if they're bed bound, or their skin is thinner and that type of things. You want to make sure that you have barriers and different things like that, because you don't want to drag the patient, you don't want to pull the patient, you want to avoid any type of pathologic fracture or injury. You want to perform or assist the patient to perform perineal care at least twice daily. um, you want to get a history, and you want to get a physical on the patient when it comes to them having decreased glucose tolerance. Do they have a history of that? You want to do they have tend to have uh, uh, like yeast infections and that type of thing? Do they have increased hunger or thirst? Do they have a decrease in the energy level? You want to notice and look, for all those type of things with the patient. Um, it can be difficult to distinguish whether or not a person is a hypothyroidism, or whether or not they're hyper. But since they have a decreased general metabolism, we already said that they are not going to be able to tolerate cold as much. They're going to have lethargy, constipation, because everything is decreased. They're going to have decreased cognition, slowed speech, body temperature, low heart rate below 60. And you basically got to teach the patient and the person to handle themselves better, and dress more warmly, and do the things that they need to do. Okay. Um, you wanna you wanna make sure that while you're doing your health assessment and everything, that there are certain type of especially with patients and stuff, there are certain things that you'll notice in them, as far as when you're doing like your physical uh, assessment. And you want to look at them, and you want to make sure that the things that you are seeing when you're examining them uh, and doing the physical assessment is not present. For instance, you want to assess them for a prominent forehead or jaw. And the reason why is because there are certain physical appearances that are going to go with uh, certain types of endocrine dysfunctions and endocrine problems. So as a result, when you're assessing them physically, you're gonna assess them for these type of conditions. Sometimes, like, people will have a round or puffy face, and you might notice that as a result of that round or puffy face, they may have some type of endocrine function. It may have something to do with them having excess cortisol in their body. You're going to look and see if they have a dull or flat expression. That goes again, like I said, with some type of endocrine disorder. And I don't want to tell you right at this particular problem, but a lot of times it may have to do with them having some adrenal corticotropin hormone problem. Exophthalmos, that's the when a person has, the real big wide-eyed, big bug eyes, what people call it, and that may be a result of a person having some type of thyroid disorder. Then they may have vitiligo, which may be something going on with the adrenocorticotropin, the adrenal, because of the fact that the anterior pituitary, there may be a problem there because they're responsible for melanocytes, which is melanin, which is the skin pigmentation. So they may have vitiligo, like patches of white, in their skin. They may have striae. Striae is reddish purple stretch marks on the breast or abdomen, which might often be seen if a person has adrenocortical excess. And then hirsutism, hirsutism, which is really basically excessive growth of body hair, especially on the face, chest, and abdomen of women, excessive hair loss or changes in hair texture. So you may see all of those type of things and you want to make sure that you assess for that. Um, Also, as you can see right here, we have proper palpation when you're trying to palpate the thyroid gland. Um, I would like for you to know, and I'm gonna state it for you guys. Um, the thyroid gland and the testes can be examined by palpation, and in order the thyroid gland primarily is palpated for size, symmetry, general shape, and the presence of nodules or any other type of irregularities. You need to palpate the thyroid gland by standing either behind or in front of the patient. The posterior approach may be easier, having the patient swallow sips of water during the examination helps the clinician palpate the thyroid gland. As the patient nicely, you're going to say to sit and to lower the chin. And then you need to use the posterior approach by placing the thumbs of both your hands on the back of the patient's neck with the fingers curved around to the front of the neck on either side of the trachea. And then you ask the patient to swallow and then locate the isthmus of the thyroid as if you feel it rising. Identify the anterior surface of the thyroid lobe. To examine the thyroid, proceed in this way. You need to turn the patient's head to the right. Displace the thyroid cartilage to the right with the fingers of your left hand. Palpate the right lobe with your right hand, and then reverse this procedure to examine the left lobe. And that's how basically you do. And you always make sure you palpate the thyroid gently because vigorous palpation can stimulate a thyroid storm in a person who has or is suspected to having hyperthyroidism. So you can observe that. I would like for everybody to just make sure that they kind of know the techniques, and be careful about how it's specifically saying that the right hand palpates and then when you're going from behind, and then the left hand displaces, and then when you're going from the beginning and your hands are from the front, the left thumb palpates, and then the right thumb displaces. So you need to know those like techniques and don't think about it too hard, but it's pretty much pretty simple. Okay. I also wanted to briefly discuss about various laboratory tests. Um, the laboratory tests that you'll be assessing for when you're talking about endocrine function, you're going to have what they call stimulation or suppression tests. Stimulation test measures specific hormone blood levels, and it does not always distinguish between the normal and the abnormal. So let's say if a person has some type of underactive endocrine gland, a stimulus may be provided to determine whether the gland is capable of normal hormone production. So it's almost like you're introducing or asking the hormone to do something out of its abnormal. So, like for example, if they give an insulin injection, it should stimulate increased release of growth hormone. So, therefore, they're trying to see if the adrenocorticotropic hormone is normal. And so, as a result, if the adrenocorticotropin hormone is produced in the anterior pituitary gland, you're looking at that whole function, you know. So that's how they're doing. Then they have what they call assays, ASSAYS, um, and they basically just measure the level of a specific hormone in the blood or other blood fluid. So that's just like them just like taking the blood work or either doing it from some type of body fluid or something. Then they have venous sampling, which is basically when you draw blood directly and then they run the test. They have urine tests, which is like a 24-hour urine, um, and they're assessing the hormone levels for metabolites in the urine or different endocrine things and overall function in the urine. And also you got to know that like it's like very specific because there are certain hormones and different things like that that may require you to have certain preservatives or things in the container, and it has to be like time for exactly 24 hours. Okay, and you may want to go back and review how you collect the 24-hour urine, and you get rid of the first and the whole process with that. Okay, test for glucose. Also you may want to do tests for glucose to make sure that the islet cells are functioning. You want to see if the pancreas have cell function, and you might have to do what they call a glucose tolerance test. You may need to do a hemoglobin A1C, uh, and the hemoglobin A1C, basically this value reveals the average blood glucose level over a period of 2 to 3 months. So that is a good indicator for whether or not a person is running a high blood sugar result. And this is when they came up with this test, it was something for people who basically well, a lot of times they would lie to their provider and say that they're not eating a certain thing, and they will appear to be they will fast before they go to the doctor, so they would be thinking that their labs and their blood work was fine. But when they came over with up with the hemoglobin A1C, it revealed that maybe the person was running a high blood sugar over the last 3 months. So there's no way that you can kind of like cheat the doctor no more like they used to do. Then they have what they call imaging assessments, which anterior and posterior and lateral skull x-rays and various things looking to see if there are any type of abnormal growth, because sometimes you can have an abnormal growth, and that growth can result in you having producing um, from a particular gland not enough or too much of a specific hormone. You can have a MRI done or a CT or something like that. And then of course they can always do what they call a needle biopsy or something like that as another type of diagnostic assessment, to indicate, like for instance, a lot of times they'll do those for when a person appears to maybe having some type of nodule on their thyroid. And that's the end of your overall anatomy and physiology review of the endocrine system, and we'll continue in just a second. Okay, we're going to talk about chapter 65, and that's care of patients with pituitary and adrenal gland problems. You're going to have safe and effective care environment. Um, so you're going to protect the patient with antidiuretic hormone deficiency from dehydration. You're going to use appropriate interventions to prevent injury in the patient with hypercortisolism. You're going to modify the environment to reduce stimulation for the patient with pheochromocytoma. Teach patients how to avoid increasing intracranial pressure after pituitary surgery. Identify the teaching priorities for the patient taking hormone replacement therapy. Teach patients how to monitor therapy effectiveness for diabetes insipidus or syndrome of inappropriate diuretic hormone. You're going to encourage the patient and family express concerns about endocrine health. Um, you're going to compare the common clinical manifestations of pituitary hypo and pituitary hyperfunction. And we're going to talk about the transsphenoidal hypophyseectomy, the SIADH, adrenal insufficiency, hypercortisolism. We're going to discuss patients with Cushing's disease syndrome, um, etc. Disorders of the anterior pituitary gland. You have what they call primary pituitary dysfunction. You have secondary pituitary dysfunction, pituitary hypofunction, pituitary hyperfunction. And we're going to first discuss what primary pituitary function is and the differences between dysfunctions from primary, secondary, and hypo and hyper function. Primary pituitary dysfunction are from problems in the hypothalamus. Let me say that again. Primary pituitary dysfunctions are from problems. Okay. Once again, primary pituitary gland dysfunctions are from problems in the hypothalamus that change anterior pituitary function. Secondary pituitary dysfunction. Um, I'm sorry. I'm take that back. Okay, let me start all over again. Um, Hormone disorders of the anterior pituitary gland can result from problems arising with the anterior pituitary gland itself. So, if you have problems that arise from the anterior pituitary gland itself, it's considered primary pituitary dysfunction. So, if you have problems that arise from hypothalamus, that change the anterior pituitary function, that is what's considered pituitary, secondary pituitary dysfunction. So either case, like I was telling you earlier, like a person could have a tumor or have some problem like that. Either way it go, then either one could result in a person having pituitary hypofunction or pituitary hyperfunction. So, a person a person that has, for instance, hypopituitarism has a deficiency of one or more anterior pituitary hormones, and it results in metabolic problems and sexual dysfunction. So if you're not having enough of the hormones, remember earlier I was telling you a list of the various hormones that were produced in the anterior pituitary, and I said the growth hormone, the thyroid stimulating, the corticotropin, the follicle stimulating, luteinizing. So they are responsible for a lot of the gonads, and that's the reason why a lot of times you'll see that there are um, problems with sexual dysfunction when a person has deficiencies or problems with hypopituitarism. Um, the most decreased production of like all of the anterior pituitary hormones is what they call panhypopituitarism. Um, Usually there's like commonly a secretion of one or any other type of hormone. You rarely would see somebody with the pan pituitarism. Um, Most life-threatening deficiencies, like I said, is the adrenal gland, adrenocorticotropin hormone, and if they have thyroid stimulating hormone problems. Remember earlier I was telling you that the thyroid is responsible for metabolism, and that's a very important function to focus in on. So if you have deficiency, like I told you earlier, of the gonadotropins, they'll have sexual dysfunction. Growth hormone stimulates the liver to produce substances known as somatometins, and they enhance also the growth activities. Um, there could be like many causes of a person having hypopituitarism. um, some of the main causes for a person having hypopituitarism would be benign or malignant tumors, anorexia nervosa, shock or severe hypotension, head trauma, brain tumors, infection, and then also the Sheehan syndrome of postpartum hemorrhage, or reasons why a person could have those type of problems. So, like I was telling you earlier, even though a person could have tumors or whatever, it doesn't necessarily have to be just for hypopituitarism. They could also have tumors, and it could put them into hyperpituitarism as well. Um, a person eating. I know that a lot of times people have seen results as a result of a person having anorexia nervosa. Um, I mean, if a person is like losing a lot of body fat and whatnot, or their body might go into like what they call like a starvation mode or whatever, and that may be the reason. Um, a person with acquired immune deficiency syndrome can also have problems with that. Also, when I was talking about Sheehan syndrome, postpartum hemorrhage, the pituitary gland, generally when a person is pregnant, um, uh, the pituitary is usually more enlarged, and when a person basically, like if they have a hemorrhage episode and then they go hypotensive, um, they can get what they call blood loss or ischemia or necrosis of the gland. And usually they say that that kind of happens like right after delivery, and they'll try to get on it right away. Okay. So, a person having patient centered collaborative care, first thing you want to do is of course, you want to make sure that you assess. You want to assess that patient for physical appearances, target organ functions occur. You want to have Like for instance, let's say that they have a deficiency in of their gonads, so they're producing less LH and FSH deficiency. Um, um, they a lot of times have a loss of their secondary sex characteristics in men and women. The male patient might have body or hair loss, and then women may report having amenorrhea, which means they might not have any menstrual cycle, decreased libido, painful intercourse, infertility, and decreased libido. Also, when a person may have a hypopituitarism, they may suffer from what they call temporal headaches. They may suffer from diplopia, which means they basically will have some double vision. Um, so, um, just because um, you're gonna assess like if a person has like a lot of times if they're TSH, which is the thyroid stimulating hormone, is working, and it's like really high because it's working hard, and a person is hypo. Um, Generally, what you're seeing is that the actual hormones, which is the T3 and the T4, are actually low. So if you, I want to make sure that like I emphasize that generally when you see like the thyroid stimulating hormone levels high, like if you draw some labs, it's because the T3 and the T4 is generally low. So um I want you to look at when a person has, once again, hypofunction, which is decreased and anterior pituitary hormone. They're going to have decreased growth hormone, um, decreased LH and FSH, decreased thyroid stimulating hormone, decreased adrenocorticotropin hormone. These are the things that's going to occur. And I wanted you to think about when you have these things, like earlier I had discussed with you that these particular hormones are contained up under the anterior pituitary. Okay. And I wanted to just really, really stress that with you. So if you got the growth hormone and you have the LH, FSH, TSH, ACTH, and all of them, you know basically what the functions of those hormones are. So if those hormones are not working, for instance, let's say the growth hormone, you know that you have a decreased bone density, the person's going to be prone to have fractures. They're going to have decreased muscle strength, and they're going to have an increased serum cholesterol level because the things that are supposed to be working to solidify them um, muscle strength and bone density is not working because you have hypofunction. And it's the same thing. Anything that seems like it's not a norm is going to be that way. In men, for instance, you're not going to have as much gonadotropin um, and LH and FSH. Okay, so therefore, in women, you're going to have amenorrhea. You're going to have breast atrophy. Everybody has decreased libido. Men, you're going to have impotence, loss of bone density, decreased body hair, where you would think in terms of men normally having more. So I want you to think about these things that way so that you'll be able to answer the questions appropriately and be able to focus in on the questions and make sure that you're able to answer them correctly. Okay, then you have what they call hyperpituitarism. and that is hormone oversecretion, and it occurs with pituitary tumors. We saw that as well for hypopituitarism. Remember, I said the tumor, and then like uh, a person having like maybe some problems as far as genetically with their pituitary gland, and also them having, like I said, a pituitary uh, tumor, which is an adenoma or hyperplasia, overgrowth of the pituitary gland. Um, like we said before, when I'm trying to compare it for you, the difference between the hypo and the hyper. Um, Gigantism, for instance, if you have hyper secretion, you're going to have an increase of the growth hormone. Like, once again, I had mentioned to you guys that you're going to have everything diminished, loss of bone growth, loss of density, loss of everything. And as a result, when you have hyper, it's just the opposite. So that's why you'll see those people with gigantism, because of the fact that the growth hormone, which is produced in the anterior pituitary, and when you have hyperpituitarism, it's going to produce more of that. Um, so if you think about it like that, and this is what they call acromegaly, and that's when a person. Remember, I was telling you when you were doing the physical examination, you're trying to find out whether or not the person has prominent bone structures and different things like that as a result. And these are the type of things that you're looking for. Patient centered collaborative care, of course, you're going to assess whether or not you're going to assess the patient for hyperpituitarism, and you're gonna usually, like, a person asks about if they have a change in their ring shoe size, or ask whether or not the person is tired and fatigued. A lot of times that's like really common. A lot of times, because of this constant growth and overgrowth, a lot of times people have joint pain, um, and they do have difficulties with sexual functioning. Um, Women, it's the same type of thought process or whatever as it is with the hypopituitarism. Um, they're going to have changes in their appearance, like I said before. And then the only way, when they do like a imaging assessment or something like that, um, they'll find and they'll see that a person has like a really overgrowth as far as their skull and their X-ray is concerned. Um, Also, suppression testing, it can also help diagnose hyperpituitarism and determine whether the normal negative feedback control mechanisms, like for example, if they have like a high blood glucose level, they can suppress the release of the growth hormone in a suppression test, and that way they can see whether or not if they do not fall below the amount that mean that they're supposed to, when you're doing like a glucose tolerance test, then that means that that's a positive level, that there's a overactive of the pituitary hormone. You can do what they call the non-surgical management. Generally, that's what people generally do. They use drug therapy and maybe used alone or in combination with some type of surgery or radiation. If a person has a tumor, the most common drugs and or like dopamine and agonists, which include like Parladel and Dostinex and Permax. These drugs, what they generally do is they stimulate dopamine receptors in the brain, and as a result of them doing that, they inhibit the release of the growth hormone. Um, and in most cases, like when a person has like a small tumor, um, uh, they use like the radiation and the therapy, and try to decrease it so it won't be making the pituitary gland so hyperactive. And even though the tumor sizes and everything may decrease, uh, as a result of a person taking these various meds, that doesn't, once they get it under control, and especially like when somebody has gigantism, they do not go back to, like the way that they normally look. They don't go back. I do want you to know some of the signs and symptoms, or the way a person looks. For instance, you can look like in your book where it shows people with acromegaly as a result of them having hyper production. Um, so, for instance, we talked about the various hormones and what they can do, and a person having, like for instance, the Cushing's disease, them having growth hormone, having the acromegaly. And if you look like on your chart on page 1376 of your book, it'll specify, because everything that I told you already, it already discussed that. So I would think that you would know these signs and symptoms that a person would have. And that's just a small picture. Also, a person can go and get what they call that uh, the transphenoid surgical approach to the pituitary gland, where they would go in and basically you're going to remove that tumor and leave the pituitary tissue undisturbed, and it's called a hypophysectomy. And the main thing that you want to uh, be is the neurological response, because you have to think about it. You are up there in close and their brain. You want to assess for postnasal drip. You want to keep the head of the bed elevated. You avoid coughing early. You don't want that pressure early on in the surgery. You want to try your best not to do this. Instruct the patient not to brush teeth, cough, sneeze, blow the nose, or bend forward after surgery. Hi. You want to avoid. You want to assess for meningitis, any hormone replacement that may be needed, because it depends on exactly which hormone was overacting. Like, was it the growth hormone? Was it prolactin, thyroid stimulating hormone, or something like that? You want to avoid bending, avoid, because you want to assess for the increased cranial pressure and be careful about that. Um, and you want to avoid straining after a stool. Avoid toothbrushing. You want to assess whether or not there's numbness in the area of the incision. Initially, that would be like normal. Sometimes people have what they call a decreased sense of the smell, and also they're going to administer post-op vasopressin. Okay, the next disease process we'll talk about is the diabetes insipidus, which is not the same as diabetes mellitus. Um, when you talk about diabetes insipidus, you want to discuss about problems with water metabolism, because there is a problem with the antidiuretic hormone. So either they may have a decrease in the antidiuretic hormone synthesis, or you may have an inability of the kidneys to respond to uh, the ADH hormone. So when you have ADH deficiency, results in the excretion of large volumes of dilute urine, and without the ADH, the distal kidney tubules collect ducts, and they do not like reabsorb the water. And as a result of them not reabsorbing the water, people have what they call polyuria, which is excess of water loss through urination. And as a result, what happens is they end up really dehydrated. There are like um, four different types of diabetes insipidus. You have what they call nephrogenic diabetes insipidus, and that's basically inherited. You have primary diabetes insipidus, and it's caused by a defect in the hypothalamus. And it's the same thing as what I was telling you. Whenever they have what they call a primary reason for that particular disease process, it's usually a defect in the actual hypothalamus. And remember, I told you that the hypothalamus is the control center, so there's actually something going on there. And then you have what they call secondary diabetes insipidus, which can result from tumors, and these tumors can be near the hypothalamus, or they can be on the actual pituitary gland. Um, Also, an example would be like a head trauma, some type of infectious process, and surgical procedures. And then you could have a drug related diabetes insipidus, and it's usually caused by lithium carbonate, and because these type of drugs can interfere with the response of the kidneys and the ADH. Right here, it's just basically showing you a picture of the process. Um, so basically, what you're going to do is you're going to assess. And because most problems that relates to diabetes insipidus are usually related to dehydration, the key manifestation is the increase of the frequency of urination, which is once again called polyuria, and they will have what they call polydipsia also, which is excessive thirst. You're going to ask about a history of any known other type of factors, such as have they had surgery like a hypophysectomy, have they had head trauma, or are they on any type of drug like lithium. Remember, I was telling you guys about that when I was talking about secondary diabetes insipidus and drug related diabetes insipidus. Um, so you're going to ask them these type of things. Um, you're going to use hypertonic saline tests for a diagnosis of the disorder. Um, if the urine is diluted with a low specific gravity, which is less than 1.005, that may really pretty much be an indication. Um, you're going to treat it, of course, and your interventions can be treated with what they call oral chloropromide. And what that drug does is it increases the action of existing ADH or antidiuretic hormone, and possibly has a stimulating effect on the production of ADH in the hypothalamus. So what you're trying to do is you're trying to get the hypothalamus to say that we need to produce more ADH, so that we can stop um, the polyuria, and prevent the dehydration. So, what I want you guys mainly to remember is that the signs and symptoms of diabetes insipidus is really, really pretty much related to a person being dehydrated. There are a lot of cardiovascular manifestations, like a person would have be hypotensive in nature. They would have decreased pulse pressures, tachycardia. Of course, if you dehydrated, your pulses are going to be weak. Um, and then when you look at the concentration of your blood work, all that is going to have an increased concentration because there's no water if you think about it like that, because you're getting rid of it. Um, you're going to have a dilute low specific gravity, like I said, less than 1.005. You're going to be hyperosmolar. You're going to have poor skin turgor, dry mucous membranes. Um, you're going to be irritable. You're going to have increased sensation for thirst. So if you think of it like that, all those signs and symptoms or what you're going to have, and you're going to make sure that people who um, have a history of diabetes insipidus, generally they have lifelong vasopressin therapy. And also, you want to make sure that you always teach people with this to weigh themselves um, daily. Okay. Then the next disease process is syndrome of inappropriate antidiuretic hormone. SIADH is a problem with vasopressin or antidiuretic hormone. Remember, I told you guys that we were going to use those names simultaneously. Is secreted even when plasma osmolarity is low or normal. So if you have a decrease in plasma osmolarity, normally this inhibits ADH production and secretion. Also, another name for SIADH is also known as Schwartz-Barter syndrome, and I did not know that myself, so we can keep that in mind. It occurs with many pathologic conditions, specifically like if a person has cancer, and with specific drugs, including selective serotonin reuptake inhibitors. Um, on table 65-1, there are several reasons and causes for syndrome of inappropriate antidiuretic hormone. Um, that could be because of malignancies, central nervous system disorders, pulmonary disorders, and drugs. And I'm not going to spot those out. You can look on page 1380. Uh, they got like, like if a person has a lymphoma, if a person has any type of chronic disease, like viral and bacterial pneumonias, active TB, any type of drugs that like opioids, tricyclic antidepressants, or any type of drugs like that can make a person have that type of reaction. Usually, when a person has syndrome or inappropriate antidiuretic hormone, um, then um, it's almost just like the opposite of what you'll see when you look at a person that has diabetes insipidus. So for that person, you want to put them on fluid restriction, and you want to have them on drug therapy like diuretics, um, and hypertonic saline, and uh, things like that that'll help them excrete the excess, because they're doing just the opposite. So therefore, where you was monitoring them when they had diabetes insipidus for dehydration and that type of thing, this time you're going to try to monitor them for fluid overload. You want to keep them in a safe environment. Um, you want to also make sure that you do neurological assessments. Okay. Then next, we're going to talk about people who have adrenal gland hypofunction. Adrenal corticosteroids may decrease as a result of inadequate secretion of ACTH, which is the adrenocorticotropin hormone. Um, so you'll have maybe some type of dysfunction of the hypothalamic pituitary control mechanism, or you may have a direct dysfunction of the adrenal tissue, which may relate to a person having decreased adrenal gland uh, function. So, as a result of a person having adrenal gland function, they may have loss of aldosterone and cortical action. So, remember, I was telling you guys earlier that a person that the adrenal gland is responsible for producing the aldosterone and the cortisol. Um, well, if you have an insufficiency of adrenal corticosteroid, well then you won't have as much. So therefore, like for on the cortical action part, you're going to have a decrease of gluconeogenesis, because remember, and you're going to have a depletion of liver and muscle glycogen. You're going to have hypoglycemia. You're going to have reduced urea nitrogen excretion, anorexia, weight loss, um, and then you're going to be having these constant potassium and sodium and water imbalances. Um, the reason this process, when you have a decrease, is called Addison's, and then you're going to have either Addison's disease, which is primary, or you're going to have what they call secondary, which is sudden cessation of long term high dose glucocorticoid therapy. Remember when I was telling you earlier that primary is usually a lot of times right within the gland, um, some type of major dysfunction, and then secondary is a result of some type of trauma or some type of drug therapy. That's the reason why. So, when you have acute adrenal insufficiency, it's considered what they call the Addisonian crisis, and usually that's a life-threatening event in which the need for cortisol and aldosterone is greater than whatever the available supply is at that particular time. A lot of times it occurs in response to a stressful event, especially when the adrenal hormone output is already reduced. And the main problem with acute adrenal insufficiency are the same as those as chronic insufficiency, but are more severe. And unless they intervene promptly, sodium levels and potassium levels and all that type of thing would drop and put a person into shock, and it occurs with the loss of aldosterone, and so it's a main emergency situation. Um, so basically, what you would do is you're going to assess the patient as a nurse and ask about any changes in activity level, because generally these people they have a lot of lethargy and they're fatigued and they have muscle weakness. You want to ask about any type of GI problems such as anorexia, nausea, vomiting, them having diarrhea. A lot of times women may have menstrual changes related to weight loss, and men may report having some type of impotence. Um, you also want to ask if they are having any type of medical problems, if they had any type of past or current drugs, especially like steroids, anticoagulants, or opioids or something like that. Um, They're gonna look at if there's any type of difference as far as their physical appearance. Sometimes you'll see people having decreased pigmentation, which I told you guys about that earlier, which is that vitiligo, and it may occur because of the destruction. Because remember, I told you the melanocytes um, was produced there, and body hair may also be decreased, and in the if they have it like secondary, which means that as a result of them having some type of trauma or something, there's really not enough time for your body to like stop producing enough melanocytes. So a lot of times you might see a person there, and if that case, then they may not have increased. Um, they may not have decreased pigmentation. I'm sorry. Um, so how would you diagnose this? You would diagnose this um, uh, by checking, like for instance, their blood urea nitrogen levels, or you want to see if they ACTH level are elevated, whether or not they have plasma cortisol levels, um, if they're rising during the stimulation test or not. Because a lot of times, if they do have it, they probably will not. You also may want to do any type of imaging assessment, and when you do the CT or the MRI, you're scanning particularly to see if there are any type of tumors or anything that's prominent on the gland. Hypersecretion by the adrenal cortex results in what they call Cushing syndrome disease, or what they another name for that would be hypercortisolism or excessive androgen production. Um, if you look on page 1384 of your text, you will see how generally a person looks when they have Cushing's disease. A lot of times I discuss this in lecture, and you'll find yourself kind of looking at people wondering whether or not they have this or not. Oh, I forgot. Let me go back. I forgot to tell you that a lot of times um, when a person has pheochromocytoma, this will result as for in hyperstimulation of the adrenal medulla, and basically what that is that's just a tumor that's sitting on the adrenal gland itself, and what it does is just the fact that it results in them like excessively excreting the catecholamines, and as a result, they'll have more cortisone secreted in their blood, and so then as a result of that, a person who has hypercortisolism is what they call like a Cushing's disease. um, a lot of times when you see a person with Cushing's disease, um, they have what they call like like that moon looking face, and some of the clinical manifestations is they say that they have weight gain, they say they have truncal obesity, they have a buffalo hump, everything is paper like. They're real prone to infection, real prone to thinning skin, um, increased, I already told you about the increased risk for infection. They usually have muscle atrophy, even though they'll seem like they're bigger or whatever. They may seem that way, but actually they don't have very much muscle. It's more like, like fat. They tend to be hypertensive. That's the way that they generally present themselves when you look at them. So you want to do when you're assessing them, and you want to do a psychosocial assessment as well. Um, um, when you do your psychosocial assessment, they generally say that people have emotional instability, and the patients often say that they do not feel like themselves anymore. Sometimes they'll have mood swings, they'll be irritable, they'll be confused, and they'll be depressed. Um, what you want to do is you want to do check salivary cortisol levels to see if there is an increase. Um, and they say saliva, not spit, is needed. Saliva is easily and painlessly collected with the use of a salivary specimen cushion. So, basically, and then also you want to check for the urine cortisol in their urine. Um, Usually they'll have an increased blood glucose level, decreased lymphocyte count, increased sodium, decreased calcium, and decreased potassium. So you may want to relate that. Um, Often you're really concerned with like patient safety when you are talking about somebody with hypercortisolism or Cushing's disease. Because a lot of times, remember I told you earlier that they would have a lot of problems with like fluid overload. Um, they may have problems with cardiac or kidneys or even with injury. Um, you also want to monitor them for like some type of pulmonary edema. Uh, you want to try to um, protect their skin from pressure areas like their coccyx area, hips, and heels. They're real prone to fractures. Um, as far as drug treatment, you may use like periactin because it may be used. It interferes with ACTH production. Mitotane, and it's an adrenal toxic agent used for inoperable tumors. Um, they though that's basically the main type of drug therapy. And then as far as monitoring the patient, you want to monitor the EKG patterns. You want to constantly assess their labs. And then as far as nutritionally, you don't want to give them no added salt or anything, no extra volume when you're feeding them. And then you want to make sure that you always check their specific gravity level, because like I said, if it's below um, 1.005, that may even with them indicate that they're going into fluid overload. Um, the main thing to do as far as surgically for these potential patients is a hypophysectomy, and we already talked about the type of things that you do post-op for that, and adrenal may be needed. So it just kind of depends on the individual patient. And we already talked about, like the post-op management, post-op for these patients. And afterwards, if you decide that a patient does need a adrenal, well, then that means that they're going to need lifetime replacement of glucocorticoid and mineral corticoid replacement after surgery. So, basically, you want, as far as being a nurse, you want to make sure that their skin is intact. There's minimal or no bruising, bones are intact, Stools, vomitings, any GI secretions contain no gross or occult blood. And as far as community-based home care managing, um, usually patients with hypercortisolism has muscle weakness and fatigue, and so you may want to necessitate one fluid living for a short time, and maybe even a home health aide may need to assist with hygiene, meal preparation, and maintenance. And also, you got to make sure that once they get up and about, you don't want them. You want them to mainly weigh themselves because you don't want them to have a 1 to 2 pound increase in their weight within 24 hours. The next disease process is hyperaldosteronism, which is uh, called Conn syndrome, and its increased secretion of aldosterone results in mineral cortical excess. So, primary hyperaldosteronism is a result of excessive secretion of aldosterone from one or both adrenal glands. Um, so, as a result, the increased aldosterone levels they affect the kidney tubules, and what they do is they cause sodium retention with potassium, hydrogen, iron excretion. So as a result, people will end up with hypernatremia and hypokalemia and metabolic alkalosis as a result. Um, so basically, when you're assessing the patient, um, what you want to assess for is elevated blood pressure are the most common problems in the patient with hyperaldosteronism. Sometimes they say they are fatigued, they have muscle weakness, and mainly excessive urination at night, which is nocturia, and loss of stamina. They will have polydipsia, which is um, um, the thirst, which in excess of fluid intake, and polyuria, which is excessive urine output. Paresthesias, which is sensations of numbness and tingling, and sometimes that occurs because of potassium depletion, and it may be severe. The interventions that may occur as a result mainly is usually surgery, which is adrenalectomy. And as I told you guys before, that'll require lifetime drug replacement of minerals, um, drug therapy. Usually what they use is aldactone or spironolactone. In other words, a potassium sparing diuretic. Um, Potassium supplements may be prescribed to increase potassium levels before surgery. Um, it kind of depends. When a surgery cannot be performed, a lot of times spironolactone therapy is continued to control hypokalemia and hypertension. So they're going to instruct the patient to report symptoms of hyponatremia, such as dryness of the mouth, thirst, lethargy, or drowsiness. And that's basically it. The next therapy disease process would be phemochromocytoma. I'm sorry, which is basically a catecholamine producing tumor that arises in the adrenal medulla. Remember earlier, you guys, when I was telling you that the adrenal medulla produces catecholamine, and the catecholamine is resulting is responsible for the fight or flight response. Yeah, that's what I was trying to think of. I'm sorry. Tumors produce, store, and release epinephrine and norepinephrine. Okay, so what you notice is the phe- the pheochromocytoma, which is the catecholamine producing tumor, uh, occur as a single lesion in one adrenal gland. Through that, they can be bilateral or in the abdomen. The pheochromocytoma are usually benign, but at least 10% are malignant. So they don't really know why people generally, produce these. But upon assessment, what you want to notice is a person who has like intermittent episodes of hypertension or attacks that range from a few minutes to several hours. A lot of times they'll have severe headaches, profuse diaphoresis, flushing, apprehension, or a sense of impending doom. Drugs such as tricyclic antidepressants, droperidol, glucagon, metoclopramide, oh my gosh, and phenothiazines are can induce a hypertensive crisis in a patient when they have pheochromocytoma. And also, like if when they have foods like aged cheese, red wine, or whatever, and they're high in what they call tyramine, they can also induce a hypertension. Patient also had reports having what they call heat intolerance and weight loss and tremors. The most common diagnostic test is a 24-hour urine collection for VMA, and which a VMA is a product of the catecholamine metabolism. Other tests that may conduct it when catecholamine levels are not consistent include the clonidine suppression test and rarely um, stimulation. They usually don't do stimulation testing. MRI or CT scans also can locate the precise location of the pheochromocytoma. Surgery is the main treatment for pheochromocytoma, and basically after post surgery you want to assess the patient's blood sugar. So hypertension when a person has pheochromocytoma is usually the main hallmark of that particular disease. Okay, we're going to discuss care of a patient with problems of the thyroid and parathyroid glands. um, You want to adjust the environment for the patient with severe hypothyroidism or thyrotoxicosis. Ensure the availability of suction and emergency intubation. You want to teach patients taking thyroid hormone inhibitors, the correct timing of therapy. You want to be accepting of patient behavior and changes in appearance. Inform patient and family members that change in cognition and behavior resulting from thyroid problems that is usually temporary. You want to compare the clinical manifestations of hyper and hypothyroidism. Know about interpretation of laboratory data. Coordinate nursing care, identify teaching priorities, and compare the clinical manifestations of hyperparathyroidism and hypoparathyroidism. Hyperthyroidism. Hyperthyroidism is another word for that is called thyrotoxosis. Um, it's usually called Graves' disease and it's the most frequent cause. Usually has a goiter, um, exophthalmos, which I told you guys was the book dyes, and pretibial myxedema. So here's a picture of someone that they claim has like the exophthalmos. And then here's a picture of someone with the goiter. Um, in hyperthyroidism, usually the excessive thyroid hormones stimulate most body systems, causing hypermetabolism and increased sympathetic nervous system activity. Thyroid hormone stimulates the heart, increasing both heart rate and stroke volume. Usually, when you look at these people, in order to identify, um, they're usually diaphoretic. Their skin is fine and soft and silky, and they have thinning of scalp hair. They're usually short of breath, and they're rapid, decreased vital capacity, palpitations, chest pain, increased systolic blood pressure, and they have a wide pulse pressure. So there's a big difference between the systolic and diastolic. They have tachycardia, dysrhythmias, they have weight loss, and they're hungry all the time, increased stools, and hypoproteinemia, muscle weakness, and muscle wasting. They have blurred or double vision, eye fatigue, corneal ulcers, increased tears, photophobia. Um, they have tremors, insomnia, increased metabolic rate. Remember, I was telling you guys that the thyroid is primarily responsible for metabolism. So you can think about everything being at a higher rate, but at the same time, these people really fatigue because of the fact that everything is just like going, you know. They have a decreased attention span, restless, they're irritable, and they're emotional liable, label. And what they do is, so for 1 minute they'll be crying, 1 minute they'll be irritable, 1 minute, back and forth. They have what they call a heat tolerance, and they will ask you about this. So, basically, when a person has a heat tolerance, and then they'll be have an amenorrhea, they'll have decreased menstrual flow, increased libido. Usually, sometimes they'll have the goiter. So, this is some of the clinical manifestations. You can look on 1394, and you can check the chart 661, and you can see most of it. They do have a sensitivity to light. I already told you guys. Also, a lot of times you can hear bruits from increased blood flow. They may be heard in the neck with a stethoscope. Um, and like I said before, they would have. This is how they diagnose. Also, you will look on page 1395, and generally on page 1395, um, they have what they call goiter classifications. If a person is hypothyroid, as it relates to a goiter, the grade 0 is no palpable or visible goiter. One, where you can't really see the mass. But if it can be palpated and moves up when the patient swallows. And then two, mass is visible as swelling when the neck is in the normal position. The goiter is easily palpated and is usually asymmetric. Okay. Um, the laboratory assessment testing for hypothyroidism involves measurement of blood values for the T3 and the T4. Um, and thyroid stimulating hormone. Also, the TSH or AB, which is are measured, which is really the antibiotics are measured to diagnose Graves' disease. The most common changes in the laboratory test for Graves' disease and other forms of hypothyroidism, you can find them on chart 662. I think I talked about that before. If a person, for instance, if they have increased T3 and increased T4. Generally, the hormones itself, they have what they call hyperthyroidism. Um, if a person has Graves' disease and they have an increased T3, increased T4, their TSH is usually low. And that's because that's been going on for a long time. If it's like primary or secondary initially, you'll find where it may be high. So the laboratory tests that they usually um, draw, or and then they do what they also do is a thyroid scan. And basically all they're doing there is they're just trying to evaluate the position, size, and functioning of the thyroid gland. Um, and sometimes they do the radioactive dye, and they have you take it prior to them doing the thyroid scan. Then they have what they call ultrasound of the thyroid, and it can just determine its size and the general composition. And then also they always do EKG. And the reason why they do is because, like I told you, that people with because the thyroid gland is the one that controls the metabolism. um, it usually shows a person being having a lot of tachycardia and a lot of dysrhythmias and atrial fib and that type of thing. So they want to catch that and treat if necessary. Um, Usually people can do non-surgical management, which includes patients' apical pulse, blood pressure, temperature, and that type of thing like that. You want to reduce the stimulation because, like I said before, they're already kind of hyped up and whatnot, so you don't want more. Um, there, you want to promote comfort. You want to give them drug therapy, um, like tapazole and PTU, which is anti-thyroid drugs. Any iodine preparations, lithium, and maybe some type of beta adrenergic blocking drugs. So those would be like Enderol or that type of med. Surgical management would basically be either a total thyroidectomy or a subtotal thyroidectomy. And just like any other type of uh, surgery, you want to look for postoperative complications such as hemorrhage. You want to look at respiratory distress. You want to look at hypocalcemia and or tetany, which results in is a result of hypocalcemia. We talked about that last unit because of the fact that a lot of times your body reacts when you take away, you know, like the thyroid right away. And remember, we talked about how that is in relation to the calcium in your body producing calcium. Also, you want to look at what they call the onset of thyroid storm or a thyroid crisis. And just to talk briefly about that, a thyroid storm or thyroid crisis is a life threatening event, and that occurs in patients with uncontrolled hyperthyroidism, and it occurs most often with Graves' disease. And so basically, what happens is it develops really, really, really quickly. Manifestations of crisis develop quickly is often triggered by stressors such as a trauma, infection, diabetic ketoacidosis, and includes vigorous any type of palpation of the goiter, any exposure to iodine and radioactive therapy, And usually it occurs after surgery. And but even though it occurs after surgery, a lot of times they say it's not real common because they tend to give people the thyroid drugs like right away. So also they said one thing that you see a lot of times on when they're testing is that you need to immediately report a temperature increase of even 1 degree, because remember I talked about metabolism and that type of thing, and they were saying that that could be indicative of a person going into a thyroid storm. Also, I'm trying to think if there is something else that I really want you to know. We talked about post-op care. Of course, you're going to look for hemorrhage, elevation of the head. Okay, I do know. They say that when you're checking respiratory distress can result from them having swelling post surgery. Um, and so you want to look at the tetany. I told you about that, or damage to the laryngeal nerve. Laryngeal stridor often is heard in acute respiratory obstruction, and so you always need to keep emergency tracheostomy equipment in the patient's room, and they'll have harsh, high pitched respiratory sounds. So you want to make sure you always keep the oxygen. You want to keep emergency trach kit available. Okay. The next thing that I want to discuss is hypothyroidism, and that is a decreased metabolism from a low levels of thyroid hormones. Another name for that is what they call myxedema, and which could ultimately lead to myxedema coma. Right here is myxedema, a picture of myxedema. Okay. So, as a result, the first thing that you want to do, of course, like we do everything, is that you want to get a history, and you want to get a physical. And a decrease in thyroid hormones usually results in a person being just like almost like the opposite of somebody with hyperthyroidism. So usually they spend a lot of time sleeping, sometimes up to 14 to 16 hours daily. A lot of times they have generalized weakness, anorexia, muscle aches, and they may have paresthesias. Now, unlike somebody with hyperthyroidism, they tend to have co- cold intolerance. So, so basically, what happens is that this person usually wants a lot of blankets and that type of thing, and all the time is saying that they're cold. Uh, so that would be an intervention to help with them. They would, of course, have an increased libido. I'm sorry, a decreased libido, unlike the person with the hyper that usually has increased. And that was something that I noticed that was a lot different. Women may have a difficulty becoming pregnant, and men, of course, have problems with impotence and infertility. There are certain drugs that are sometimes known for impairing thyroid function, like I told you before, like lithium um, and such, and a few cardiac drugs, such as amiodarone, which has a damaging effect on the thyroid gland. Also, when you're taking a history, you want to determine whether the patient has ever been treated for hyperthyroidism and what specific treatment was used. So, you want to do your physical assessment, and usually, when you do your physical assessment, the person usually is just very has coarse features. They a lot of times they have edema around their eyes and face, a blank expression. For whatever reason, a thick tongue. The patient's overall muscle movement is slow. He or she may speak clearly and may take a long time to respond to questions. Everything cardiac is decreased. Body temperature is decreased. Weight gain is very common, and depending on the cause of the hypothyroidism, the patient may have a goiter. So it just kind of depends. So a lot of times they're going to say that when you're doing a psychosocial assessment, that the patient may be very lethargic, and sometimes they say that they're apathetic or drowsy. Patients may say that they um, may be withdrawn and have reduced mental function. So you want to assess his attention span and or memory, both of which can be impaired by hypothyroid. And weight gain may have a negative effect on body image, and the mental slowness can contribute to social isolation. Laboratory findings for hypothyroidism are the opposite for those for hyperthyroidism. So the T3 and the T4 serum levels are decreased instead of up, and then the TSH levels are high in primary hypothyroidism, but can be decreased or near normal in patients with secondary hypothyroidism. Okay, so what you want to do. I would like for you guys, because it always comes up too, that we always have to look at analysis, like what type of problems that person might have. So, like if, for instance, if nursing care plan like would be presented to you, which will be the priority problem for a person with mixed edema or hypothyroidism, or so like you can look where it says altered cognitive function related to impaired brain metabolism and edema. That's a problem for someone. Uh, Decreased oxygenation related to decreased energy, obesity, muscle weakness, and fatigue. So you can look at some of those problems. Um, and then we already discussed. I already said about the. So as far as home care management, basically it's usually a chronic condition. Patients with hypothyroidism are managed on an outpatient basis and may reside anywhere. Patients in acute settings, subacute care settings, and rehabilitation centers may have long standing hypothyroidism in addition to other problems they may have. The worst thing would be for them to potentially have what they call a mixed edema coma, which you would maintain a patent airway, replace fluids. You would give them levothyroxine, sodium, so thyroid meds, give glucose IV, give corticosteroids, check the patient's temperature hourly, monitor the blood pressure because that goes down. So aspiration, precaution, and that type of thing. Um, so basically, what you're going to be teaching the patient is for the patient to manage their self at home and take their thyroid hormones, and which they should probably pretty much take on an empty stomach. Um, and make sure they get their rest and any type of counseling or anything that they need. Okay, thyroiditis. Thyroiditis is an inflammation of the thyroid gland which could occur which they have three types. Um, you have what they call the acute thyroiditis, which it's caused by a bacteria. Um, Manifestations include pain, neck tenderness, malaise, or them being tired, fever, and dysphagia, which is difficulty swallowing. And usually they treat that by antibiotic therapy. They have what they call subacute thyroiditis, and it results from a viral infection. Um, and that comes after a person has potentially had a cold or respiratory infection. Manifestations include fever, chills, dysphagia, and muscle and joint pain. Um, um, a lot of times, a thyroid function test can remain normal, although hyperthyroidism or hypothyroidism could potentially result, and that will probably be, they call that the chronic thyroid um, itis, which is Hashimoto's disease, and it's a common type of hypothyroidism that affects women more often than men, usually when patients are in their 30s to 50s. Hashimoto's disease is an autoimmune disorder that is usually triggered by a bacterial or viral infection. The thyroid is invaded by antithyroid antibodies and lymphocytes, causing thyroid tissue destruction. So when large amounts of the gland are destroyed, um, usually the TSH level is usually increased. Um, Usually, people have when they have that Hashimoto's disease, they have dysphagia, painless enlargement of the gland. Um, they usually diagnose it by doing a needle biopsy of the thyroid gland. Um, and usually they do TSH levels and they do a radioactive iodine uptake. The patient is given thyroid hormone to prevent hypothyroidism, and so that you won't secrete any more TSH or thyroid stimulating hormone. Um, Surgery, they could get a subtotal thyroidectomy, and that's only if the goiter that they have don't respond to the thyroid hormone. And nursing interventions focus on promoting comfort and teach the patient about hypothyroidism drugs and surgery. Okay, then you have what they call then we'll talk about thyroid cancer. Thyroid cancer, you have four different types: um, papillary, follicular, medullary, and anaplastic. Usually, the initial manifestation of thyroid cancer is a single painless lump or nodule in the thyroid gland. Um, Papillary carcinoma is usually the most common type of thyroid cancer. It occurs most often in younger women. It is a slow growing tumor that can be present for years before spreading to the nearby lymph nodes. When the tumor is confined to the thyroid gland, the chance for cure is good with a partial or total thyroidectomy. Then you have secondary or follicular carcinoma, which occurs most often in older patients. The cancer invades blood vessels and spreads to the bone and lung tissue. It can adhere to the trachea, neck muscles, great vessels, and skin, results in dyspnea, and really results in difficulty breathing, dysphagia, I'm sorry. When the tumor involves the recurrent laryngeal nerves, the patient may have a hoarse voice. Um, Medullary carcinoma is most common in patients older than 50. This tumor often occurs as part of a multiple endocrine neoplasia. And type 2, a familiar endocrine disorder, looks like it says in men. The tumor usually secretes calcitonin, um, adrenocorticotropic hormone, prostaglandins, and serotonin. Okay. Then anaplastic carcinoma is a rapid growing aggressive tumor and that directly invades nearby structure. And usually people have stridor, hoarseness, and dysphagia as a result. Um, Usually collaboratory um, care would be radiation therapy to uh, potentially shrink the tumor. Um, and they it just kind of depends on whether depending on what grade the tumor is and how long it has been, if they do it surgically or and how they collaborate. So it really wasn't like real clear on that. Then you have hyperparathyroidism. Um, and as I told you earlier about the parathyroid glands, they maintain calcium and phosphate balance. Um, and it can result as just like with anything else. A person can have um, a tumor or something like that. Um, so if you have they don't really know what the triggering mechanisms are for a person when they have primary hyperparathyroidism. Um, but all they know is that the parathyroid glands tend not to respond to the normal feedback of serum calcium. So as a result, they say that it could be like an adenoma on the parathyroid, like we talked about earlier, some type of carcinoma. It could be like from birth, where a person could have some type of congenital hyperplasia, neck trauma, radiation. Also, a person could have a vitamin D deficiency over a period of time. Also, chronic kidney disease, or they could be secrete some type of carcinoma in either the lung, kidney, or GI tract. Um, there is causes of hypoparathyroidism is surgical or radiation induced thyroid ablation, a person having a parathyroidectomy, and of course hypomagnesemia and just a person being born as such. Okay. So, as far as non surgical management, um, for a person with hyperparathyroidism, you would have diuretic and hydration therapies because you're trying to reduce the level of calcium in patients who may possibly not be candidates for surgery. And this could be done with furosemide. You're going to do cardiac monitoring because you know, like we talked about, the EKG changes when you have changes in calcium levels. You're going to prevent injury because if a patient has chronic hyperparathyroidism, there may be a significant bone density or loss, and so that would make a person at risk for pathological fractures. You want to give them drug therapy, of course, like I told you before, with even though a person like calcitonin or something like that. And as far as surgical management, the surgical management of hyperparathyroidism is, of course, a parathyroidectomy. And you're going to do the same thing that you do most. You're going to assess for respiratory distress. You're going to keep the emergency equipment at the bedside. Of course, like they say, a hypocalcemic crisis can always occur. A person could potentially have a seizure, so you want to make sure you want to check for the trousseau and chapt signs, because either one of them could indicate that a person is going into like tetany and get ready to have seizures. And as a result, also recurrent laryngeal nerve damage can occur. And lastly, hypoparathyroidism, and that's just decreased function of the parathyroid gland. Um, it could be iatrogenic hypoparathyroidism. It's the most common form. It's caused by removal of all the parathyroid tissue, which may have been a deliberate surgical removal. Um, then idiopathic hypothyroidism can occur spontaneously. The exact cause is really kind of unknown. They say that it could be just an autoimmune disorder. And then lastly, hypomagnesemia may cause hypoparathyroidism. And hypomagnesemia is seen in alcoholics and in patients with malabsorption syndrome, chronic kidney disease, and malnutrition. So basically, you want to ask about whether or not a patient may have had neck surgery or radiation therapy. You want to assess for numbness around the mouth or in the hands and feet. Um, you want to look at the signs that I told you of tetany, like the trousseau sign and chapt sign. You want to look at their teeth. You want to see if there was any enamel loss, and then you're going to perform any diagnostic tests like labs, EEGs, CT scans. You're going to get the serum calcium, phosphate, magnesium, vitamin D, those type of things. And usually, non-surgical management would include correcting the hypocalcemia, the vitamin D deficiency, or the hypomagnesemia. Um, you want to make sure, if required, you might have to give IV calcium. Um, uh, or calcium gluconate over 10 to 15 minutes. And the same, replacing the magnesium IV. And then after a while, what may generally happen is they may give long term therapy as far as for vitamin D deficiency and low range. Other than that, that would be it. Okay, thank you.